My mandate over the next 10 minutes is tell you all the options of advanced or metastatic breast cancer and help you decide what's the right thing and how to choose wisely. So worldwide, almost 10 to 15% women present with de novo disease, which is metastatic. In India, this figure is much closer to 20-25%. All the clinical trials we have in this setting are enriched, and the survival, no doubt, has increased in the last 3 decades, but still remains pretty disappointing. So this is a lovely article that was presented in the Journal of NCI by George Sledge and his colleagues, and they actually looked at the 10-year incremental benefit in survival with the newer treatments and the impact it had. And they looked at the median survival, and so I'll draw your attention to 1990 and then 2010. And for ER positive disease which has recurred, the survival improved from 31.6 months to 56.5 months. For ER negative disease, it wasn't that great, 14.1 to 32.6. And if you look at the median survival of de novo stage 4 disease, it improved from about 19 months, which is a year and a half, to 31 months. So certainly we have made strides, but are these strides enough? So when you're working up a patient who comes to you with metastatic breast cancer, what is the minimum you should do? And do you really need fancy molecular tests? The answer is no. You just need a good ER, PR, and HER2 to make your clinical decisions if the patient is presented with metastatic disease. When it comes to the question of rebiopsying, please do it in the right clinical context. You have a patient who's ER positive, who years later on adjuvant hormones or just having finished hormones develops just bone-only metastasis. You don't need to go around running to biopsy her to look for anything, because you know you're dealing with a luminal breast cancer. The discordance rate is just about 15% and this is an average of most studies. What about staging the patient? Every place doesn't have a PET scan. Every patient doesn't need a PET scan. You have a good CT machine. What I do in some cases for patients living far away, ask for a CT chest to cover the liver and ask for bony windows in case there is no bone scan facility. So you can make do with less and get the same information. Now there are certain algorithms that ESMO came up with for treatment of various subtypes, and that's how we look at metastatic breast cancer. It's not one disease. So if you look at the ER positive subtype, you've got to make up your mind, is she premenopausal, is she postmenopausal? If she's pre, ovarian suppression of some sort is mandatory for the best benefits. And then you have a host of agents ranging from tamoxifen, AI, fulvestrant, and of course the new CDK4/6 inhibitors. One thing to remember is in the postmenopausal group, there's been a recent trial that was published which combined fulvestrant and AIs and gave you a survival benefit of almost 8 months. And this is pretty much similar to what we are seeing with the CDK4/6 inhibitors. So if your patient can't afford these expensive agents, then this really is a valid option. Now, chemo is only in visceral crisis. The definition, however, is still nebulous. I have a patient who's severely breathless due to a lymphangitis carcinomatosis. That is a visceral crisis, not a pleural effusion, because I can easily tap it and get her back to baseline. If she has deranged liver functions, that is a warning sign in presence of widespread liver metastasis, or a very symptomatic bone marrow involvement where you need to come in quickly with combination chemotherapy. But in ER positive disease, with the advent of the cyclin D inhibitors, the definition of visceral crisis is changing. A patient with liver mets, mild derangement, you can still get away with using hormonal therapy and CDK4/6. So this is extremely important when the patient walks into the clinic, in which category I put her. Is she endocrine naive? She'll respond to anything. Is she sensitive in the sense, has she relapsed 1 year out after adjuvant therapy is completed? Does the patient have secondary resistance? Is she relapsing while on adjuvant therapy between 2 and 5 years, or less than a year after completing it? Or if she's metastatic, is she responded for at least 6 months to hormones and is then relapsing? Or in the worst case scenario, does she have primary resistance? These are the bad patients. These are the ones that require chemotherapy sooner. They relapse while in the first 2 years of adjuvant, or they don't even have a response in the metastatic setting and they progress. So I'm not going to go through this in detail. This data is very much available. What you see on your left side are the clinical trials for first line CDK4/6 inhibitors. On the right side, you see the second line trials, and I have pointed out, I've once again emphasized the populations of these trials. Why have I done that? Because we try applying the CDK4/6 inhibitors to patients who are truly second line, thinking we will get these fantastic first line benefits. Expectation of the patient goes high, expectation of the doctor is unrealistic, only to realize the patient has relapsed within 6 months. So if you are spending all that money on a CDK4/6 inhibitor, which no doubt is giving you an overall survival benefit, the best time to use it is upfront, where you get the most for your money, and you can provide a progression-free survival of close to 2 years. So it's important again to select out. Is it possible to show a survival benefit? Yes, in both the first and second line setting. There are lots of studies, and even ESMO this year had data from Mona Lisa 3 and Monarch 2, where you had a good 8 to 10 month improvement in survival after the addition of these agents. Are these agents equal? No, they vary in toxicity, they vary in off-target selectivity, and when you're selecting these patients in the clinic, be very wary that you are aware of the unique toxicities to each drug. For example, you would not use ribociclib in a patient with cardiovascular disease. You would choose wisely because of the thromboembolic events and the QTc prolongation. Similarly in elderly patients, similarly in patients with comorbidities. There is a newer drug called alpelisib, which we are using in hormone-sensitive breast cancer, but for that you have to test for PIK3 mutations. Don't just try it because it's available or you're getting it on compassionate use. This is again going to be an expensive drug, and we need to be very careful because so far it has only shown you a PFS benefit. The OS data is yet immature. So I would just hold on to my horses. If the patient can afford every single thing, yes. Patient progresses, you would do the mutation status. What about HER2 positive disease? And this is perhaps the disease where you get the most out of what you spend. It is a nice disease to treat. Even in the metastatic setting, patients are living for years with metastatic disease. So you have different types of patients, patients who've never had anti-HER2 therapy, patients who've had it in the adjuvant setting, and then there is a class which is elderly, cannot tolerate the chemotherapy, long disease-free intervals, say 5 years after adjuvant therapy, and a very small disease burden. So these are the patients where you can probably get away with single agent trastuzumab. In the others, a dual is preferred, but please don't think that you're depriving the patient. If the patient can't afford dual therapy, you're good with trastuzumab and chemotherapy alone, and you can possibly try and enroll the patient on a trial later. Remember that the first line dual anti-2 therapy was mainly driven by the survival benefit, or in terms of survival benefit, by the treatment naive population, right? And that's not what we're seeing in the clinic. We're seeing patients who've been previously treated. If the relapse is within 6 months, you're dealing with a resistant population, TDM1 is recommended. However, don't be disheartened if your patient can't afford TDM1. Lapatinib, trastuzumab, lapatinib with another chemotherapy, trastuzumab with another chemotherapy works pretty well, is way cheaper, and is well tolerated. So there are lots of options, and Trast chemo is a reasonable first line option. LAP-CAP is still a reasonable second line option. What about ER positive disease? So we see the subset in clinical practice, which is behaving more of a luminal type. The patient has a long disease-free interval, very tiny disease, bone nodal disease, and has a strong ER-PR expression. In my practice, I have treated some of these patients with hormonal therapy alone, and they have done exceedingly well, or with a combination of trastuzumab and hormonal therapy. So similarly, you divide them into patients who've not seen trastuzumab before, patients who've been pre-treated, and there is recent data from the Monarch of a chemo-free combination. So using trastuzumab, you're using a CDK4/6, you're using fulvestrant versus chemo plus trastuzumab. The PFS was superior. So this is something to think about in the richer subset who want to avoid chemotherapy. So where are we going? We are going in a very expensive direction. We are going into antibodies, bispecific antibodies, ADCs, those are antibody drug conjugates, and novel TKIs, which are excellent for the brain and CNS HER2 positive metastasis. And this is just one of the newer ADCs which has been tried. The efficacy is not only in HER2 positive, but even in HER2 low breast cancer. So this is intriguing. What about triple negative? This is a real problem in our country. 20 to 25% of our population is triple negative, and a lot of them relapse in the first 4 years after adjuvant disease. And the morphology is very variable. You'll have the invasive ductal, lobular, and neuroendocrine. Then you have metaplastic, high grade, and at the bottom of the spectrum with the better prognosis are adenoid cystic and the low grade metaplastic. And this is a disease of subtypes again, as I mentioned earlier. So what are we looking for? We're looking for the chemosensitive patients who are BRCA-like or are BRCA mutated. They have a very high PAT-CR rate, and they fall within the basal 1 and 2 group. There have been several subclassifications for this disease, and this is one of them. PARP inhibitors have been reserved for patients with germline BRCA, and their data from 2 trials using olaparib and talazoparib saying there's a PFS benefit, no OS benefit as yet. And recently in the ESMO, there was a data for a third PARP inhibitor with chemotherapy upfront. So you are getting greater responses, but the cost is pretty prohibitive. And should we then, and that is the underlying question in ovarian cancer as well, give PARP inhibitors or just use something cheap as carboplatin? And there has been a study called the TNT study, which has used carbo first line, and in germline BRCA mutated patients actually found a great doubling of the progression-free survival. So in patients who can't afford PARP inhibitors and who are BRCA mutated, platinums are an excellent substitute. What about the PD-L1 positive population? So this is used in the immunomodulatory. Immunotherapy has been pretty disappointing. The checkpoint inhibitors, the responses haven't been great. They varied between 5 and 20%. And the latest keynote study, the 119 study, has shown a clear trend in improved efficacy with the enrichment for the PD-L1 population. The most convincing study, of course, was presented last year at ESMO. Atezolizumab with nab-paclitaxel was given and achieved its primary endpoint, which was improved progression-free survival. And especially in the PD-L1 positive population, the overall survival also was significantly improved by 7 months. So for 7 months, you are getting 7 months extra in this metastatic population, but you have to drop about 30 lakhs for that. So that's the context in which you have to look at it. The third subtype is the androgen receptor positive. I have had a little experience in treating these triple negatives, and they have an indolent course. They behave like ER positives. They don't respond to chemotherapy, and the drug used is enzalutamide, and you can get responses. Abiraterone is being used. Bicalutamide is a cheaper option, and patients get a good progression-free survival. Antibody drug conjugates have also been used for triple negative disease. In summary, the landscape of metastatic breast cancer is continuously evolving, but it still remains an incurable disease. The survival improvements that I showed you are mainly due to anti-HER2 treatments and now due to CDK4/6 inhibitors. The importance of pain control, the use of bisphosphonates, and palliative radiation wherever indicated cannot be overemphasized, and as far as possible, these form the backbone of care in metastatic cancers. It's important to maintain the quality of life along with symptom control, and you have to integrate this with lifestyle modifications. Thank you.